Good morning, and it's a privilege to be here in what is the first Mecca of rheumatology in India. The diagnosis, now juvenile dermatomyositis to an audience mainly consisting of adult-based rheumatologists. I'm just trying with my talk to highlight what are the challenges and the differences in children with this disease. Now, when a child presents like this with obvious heliotrope rash, Gottron's papules, and proximal muscle weakness with elevated muscle enzymes, it's not difficult to make a diagnosis of juvenile dermatomyositis. The problem comes when they present in ways where it can be difficult to actually clinically elucidate that the problem here is myositis. So this is a 8-month-old child. She actually presented as a fever of unknown origin. She was referred by pediatricians in another hospital, and she had 4 weeks of high-grade fever. She was very irritable. She was not toxic. She certainly wasn't energetic at all. But muscle weakness is not something that was being reported. And in a child who's febrile, unwell for 4 weeks, you don't really expect them to be running around anyways. That's not the first thing that people think about. She had a history of skin rashes 6 months ago, for which she underwent treatment with homeopathy. On evaluating her, actually, we found she had normal counts and elevated and rising LDH. Her other enzymes were actually normal. She had a normal peripheral smear. And to be honest, in a child who presents with pain, fever, not energetic, with a rising LDH, my first thing is to rule out a bone marrow malignancy. So the first thing we did was a bone marrow, which was normal. And that's when I re-examined her, looking at everything again, and I realized that this child actually has a proximal muscle weakness, and she had a single Gottron's papule on one of her DIPs. And so we did an MRI of her eye, and we were able to establish the diagnosis beautifully and start treating her. This is another child, a 6-year-old child, is an evolution of disease, and the problem again with children is that people don't think about this diagnosis and think about it in evolution, so it takes a long time for them to reach the right person. So a 6-year-old child who presents with alopecia to a dermatologist, who unfortunately didn't think how rare it is to get a primary alopecia in a 6-year-old child, and just started treating the child with steroid pulses, oral steroid pulses. Over time, she started developing skin rashes, for which she was getting again non-specific therapy, and then she presented at 9 months of age with features of muscle weakness, severe wasting, and other rashes typical of a JDM. And so a diagnosis was made, and she was started on appropriate therapy, to which she improved very nicely. 4 months down the line, she presented with now a pyrexia of unknown origin, which turned out to be miliary TB and a pleural effusion. And so she was started treatment for that with some reduction in her immunosuppression. However, when she recovered from the TB, she went into a full-blown, again, a JDM with pulmonary involvement. Now she had ILD, she had skin ulcers, she had pulmonary hypertension, and she required, again, high-dose steroids, cyclophosphamide, sildenafil, and rituximab, in addition to home oxygen. What was surprising was she responded to all this beautifully, and we were able to, she's today off steroids, just on mycophenolate alone, and with everything else stopped, and back to school and attending things normally. She also has a learning difficulty, which throughout the process, that was another thing that impaired our ability to make a diagnosis in her. And you can see the chest X-ray and the CT changes initially and how beautifully they have resolved below. Another child, this child presented to our pediatric department, again with a high-grade temperature. For 2 weeks, she was very febrile, very, very irritable, and she had generalized edema. They noticed that she had hypertension, significant hypertension. She was on 3 antihypertensives with very high AST and ALT. The one thing is the pediatricians realized that they were dealing with a multi-system disease, and that was the only reason why I was called to come and see this child. And when I examined this child, she had absolutely no skin features other than she was a big bag of water. But however, when I examined her, I realized she was extremely weak and had a neck flop. And the edema was very tender. That's when we did the active muscle enzymes, which were extremely high. And an MRI helped us again, and we were able to get a diagnosis of myositis. We started treating her. One of the caveats when you treat patients like this, when they have such severe subcutaneous edema, is that you have to give them IV steroids. Even when you go to, other than the pulse, even their daily steroid dose has to be given IV till the edema is completely subsided, because they will not actually absorb oral medications very well. There is a proxy GI vasculitis in most of these patients. So, and she did extremely well. She's again now in remission and doing well. But it was very tricky to pick up the diagnosis in such a young child who had absolutely no typical skin features of juvenile dermatomyositis. Another 8-year-old child who presented with fever of 3 weeks and macrophage activation syndrome. And in the process of evaluation, we noticed that she had a faint heliotrope rash, which gave us the clue to going ahead and checking her enzymes and making a diagnosis. And this was a child in whom, because of the clinical presentation, we used steroids and cyclosporin A initially before we moved her to methotrexate. And sometimes when you make the diagnosis also, the complications can take you by surprise. So a 5-year-old child with a very classic, typical dermatomyositis presentation, and then we started her on treatment. She actually had very severe muscle weakness, and she needed considerable steroids in the initial phase. She went home, started improving, came back 5 weeks later with severe abdominal pain, and you can see she's got a gastrointestinal perforation. She went for an emergency laparotomy, and what we found was a single colonic perforation. We were expecting, the first thought in our mind was a GI vasculitis, but her background disease actually was looking far better than it was at initial admission. And the biopsy was very helpful. There was no GI vasculitis, but she had CMV, which was the cause of the perforation, CMV colitis. And we treated her CMV colitis and maintained her disease treatment as well, and she's doing extremely well. So the point, a perforation in a child with JDM, you shouldn't always think it has to be a complication of the disease. It could be a complication of our treatment as well. So when you look at the inflammatory idiopathic myositis in children, the by far commonest clinical group at presentation are the dermatomyositis. The rest of the clinical subsets are far less common in incidence. And I don't actually think I've ever seen a necrotizing myopathy yet in a child. Because in that kind of presentation I would do a biopsy, and I haven't yet come across one like that. So these are very, very rare. Atypical presentations, however, rule. The clinical heterogeneity in picking up the diagnosis can be considerably wider than you see in the adult clinical arena. And that is where I think it requires a lot of participation from pediatricians and from pediatric dermatologists to get the diagnosis itself in some of these patients. Amyopathic, hypomyopathic are less common, but they do exist. Like this girl whom I met a few months ago, she, from the age of 1.5, she's having skin changes suggestive of dermatomyositis. So heliotrope rash, she's 13 when she first presented, heliotrope rash, Gottron's papules, and she's developed lipodystrophy and metabolic syndrome. In evolution, she had hypercholesterolemia and very high, she's not yet frankly diabetic, but very high glucose metabolism in this area as well. But this child had a period in her toddler days when the mother describes that she had muscle weakness. At present, she has no muscle weakness whatsoever. She's an active dancer, she's a sportswoman. Despite all these, her different appearance, she's actually very active and performs very well in every other manner. Because of her presentation, Her MRI was not suggestive of active myositis, but it still shows atrophic skin inflammation as well as calcinosis. She has a number of small calcinotic lesions distributed over her body. So this again is a case of dermatomyositis progressing with lipodystrophy and metabolic consequences. And this is a hypomyopathic form. So the incidence, it's a rare disease. And because it's a rare disease, I believe that dermatomyositis should be treated in centers which have the experience to do so. They do need to be referred to centers of expertise. Normally it's diagnosed between 4 and 10 years of age. JDM patients are younger than JPM. Polymyositis, I've seen, it is definitely significantly rarer, probably would form about 10 to 15% of the number of patients we see compared to JDM. There are no racial differences and girls seem to be more affected than boys. So there are a number of skin changes that can indicate active disease, and subcutaneous edema is one of them. Regarding calcinosis, there's a controversy whether it exists, it can indicate active disease or chronic disease. I think it has a role, depending on the clinical context, it can present one of the two. The other feature here is that many children, like I've shown you, because especially from my home state where alternative medicine is popular and other sometimes skin changes can be treated and they can be partially modified by therapy, so you may not see very clear skin changes in these patients. But when you see somebody who has probably some weakness and with raised ALT, AST, you have to have the question in your mind, could it be JDM? And that is probably the only way we will actually pick up more and more patients with the diagnosis. The differential diagnosis we've dealt with, and it's all other conditions that cause myopathies. And the diagnosis, again, the Bohannon and Peter criteria. What has happened over time is that there is a significant reduction in needing to do muscle biopsy in these patients with the advent of MRI, and certainly a reduction in the need to do EMGs in these patients for the same reason. So we have the International Consensus Survey for Diagnostic Criteria for JDM, which came up about a decade ago. And additional criteria were laid in, which included muscle MRI, ultrasound, and nail fold capilloscopy, etc., so which has actually given you an opportunity to do away with the need for biopsy in all patients. And certainly, I'll come to that. We have measures of disease activity, which is CMAS or MMT8, and the cutaneous assessment tool also exists. My personal favorite is I use the CMAS very widely. We must remember that muscle enzymes, active muscle enzyme increase only is present probably in the first few months of disease, and so it's going to be only outcome tools like CMAS, etc., which can help you monitor the disease in the long term. And the pathogenesis, in the early stages, you could have a small vessel vasculitis, but it is largely a vasculopathy, which is type 1 interferon mediated in the long term. And this is by far the most important thing. So what are the differences between idiopathic inflammatory myositis in children and in adults? One is the incidence of calcinosis. So children are by far more programmed to get calcinosis compared to adults. The MSAs we've had a lot of discussion now from both Dr. Lisa and from Dr. Vinita Shobha. The MSAs are different. The common MSAs are different in children and adults. In children, the anti-TIF1, which is the P155 and P140, which actually there's a typo in my slide, are actually the commoner ones. But interestingly, these are not associated with an increased risk of malignancy as seen in adults. The other thing is the NXP2, which is associated with the calcinosis type of JDM, and the anti-MDA5. Despite that, the interstitial lung disease is less frequent in children, although it is associated with a similar MSA as compared to adults. Mortality is overall lower in juvenile idiopathic inflammatory myositis compared to adults. malignancy is, the association is so weak that there is absolutely no need for routine screening for malignancy in these children at diagnosis. Other systems, so systemic features are probably far more common than you could see in the adults, fever, weight loss, etc. Small joint arthritis is also something that can be seen with a certain degree of frequency. Lung involvement is often seen later on in presentation. If it is seen early in presentation, it does denote a very, very severe phenotype. GI disease can be seen early or late and denotes severe disease again. Cardiac involvement can be seen, which denotes severe disease. And very rare, but definitely denoting a severe phenotype is the involvement of the central nervous system. What investigations? All muscle enzymes to be done at the point of diagnosis so that you know which one is raised in this patient and which one you can use for follow-up. It's not at all surprising even if you have all enzymes normal. I have seen one or two patients with typical JDM and all enzymes to be normal. The reason for this can be multifold. It can also be because the patient's a bit chronic by the time they present to you. And MRI without contrast, the stir sequences is something that we use very, very frequently in juvenile dermatomyositis because to do a muscle biopsy often involves a general anesthetic in children. And general anesthetic and the wound of the muscle biopsy can actually impede their immediate progress even more than you think. And I will be honest, from where I am, for me getting reliable results from muscle biopsy is also not that good yet from my point of the world. So by the time we get a result back, it takes a very long time. And in also knowing right now with the biology of the disease and everything else, we don't prefer to use muscle biopsy in all patients with JDM. If we have atypical cases, no skin changes, or skin changes without muscle involvement, or very atypical presentations, we would definitely do a muscle biopsy. But not in your classic cases, it is not necessary to do one. High definition ultrasound can definitely be helpful, but it's very skill and operator dependent, so it's not something that we can advocate for everyone. Investigate the other systems according to presentation. Every child will get a baseline pulmonary function test and an X-ray chest and a baseline cardiac evaluation with an echo at diagnosis. We don't do more than that unless there is a clinical necessity to do so. 80% are ANA positive, and I don't routinely do ENAs in my patients unless clinically as a guide to doing more than that. I wish I could do muscle-specific antibodies for all my patients. It would really help with prognosticating at the onset of disease. I do not, most of my patients cannot afford it, and at 35,000 rupees for the test, I can find better ways for them to use it. So at present, I don't. But this is something where I would consider an improvement we could definitely progress to. Especially after this recent article from 2016 from Great Ormond Street, where they were able to show muscle biopsy findings in combination with MSAs, which aid prediction of outcomes in children with juvenile dermatomyositis. So what they've shown, one striking finding was, in those few patients with anti-MI2 autoantibodies, the odds of remaining on treatment were 7.06-fold lower, despite muscle biopsy scores indicating more severe disease. Similarly, they were able to show, based on a combination of both muscle biopsy and the MSA, how you could predict severe disease and the need to stay on longer therapy for a longer period of time, which is a very, very useful piece of information you can have at the point of diagnosis. And this probably is the way we need to go forward. Clinical severity is determined by degree of muscle weakness, the presence of pharyngeal muscle weakness, cutaneous ulcers, cardiopulmonary involvement, GI involvement, and severe subcutaneous edema. The patients with severe subcutaneous edema are very, very prone to developing calcinosis in the long term, and using IV steroids continuously in the initial phase of disease has been shown to have a reductive effect in this manner. There are supportive general measures in treatment: sun protection, bone protection, nutrition. A very, very important aspect is nutrition, and physiotherapy and occupational therapy. But the specific therapy, it's a rare disease, very few clinical trials on JDM alone. The one we have is a Pinto-run randomized open-label trial where they compared prednisolone alone. For 2 years, they looked at prednisolone alone, prednisolone with cyclosporin A, and prednisolone with methotrexate. And they found that the combination groups had better outcomes and less toxicity. And what in practice we find, as recommended by the CARA group as well, using higher doses of prednisolone initially, 2 milligram per kilo, and subcutaneous methotrexate upfront improves the response of therapy. And this is what the CARA group is currently doing. They have 3 treatment plans, which is similar to what I just outlined, where you have degrees of severity and enrolling patients on just the initial 3 days of methotrexate, starting with oral pred and subcutaneous methotrexate, and they have recommended subcutaneous unless only oral is possible. So there is definitely a bias towards trying subcutaneous methotrexate in these patients above oral methotrexate. IVIG in those patients with severe disease. Now, the other aspects of treatment, if they had severe disease at onset, severe muscle weakness, we would give IVIG at onset. Those who have very severe cutaneous disease, including ulcers, severe cardiopulmonary disease or GI disease, IV cyclophosphamide would be preferred upfront in these patients. With refractory disease, there are a number of things. Infliximab has been, there's few small trials which suggest it can be helpful in children with calcinosis, refractory calcinosis. Etanercept has not been found useful. Only infliximab and adalimumab have in those few patients. Rituximab, though it didn't meet the endpoint in the trial designed for refractory disease, it was shown to have a use in small groups of patients with refractory JDM. Mycophenolate is a very, very useful drug and emerging more and more as a good secondary agent, as is tacrolimus. Whether the future holds a role for JAK inhibitors, considering the increasing understanding of type 12 interferons in the pathogenesis of this condition. And there are many complications, so when you have severe systemic involvement, development of contractures. Contractures can be present in active disease also. Development of contractures is a complication. It can significantly interfere with mobility and progress in the long term. And that can herald a series of other complications. Calcinosis is a big problem. Dr. Amita is speaking specifically on that tomorrow, so I will not talk much about it today. Infections in these patients, as I've outlined before, drug toxicity, lipodystrophy, and the metabolic syndrome. I have 3 patients who came to me probably more than 7 years into the diagnosis. All 3 of them have lipodystrophy and metabolic syndrome, and similar reasons, early onset atherosclerosis. You can see a boy with contractures and calcinosis in the top half. And this boy, the one in the middle, he has both contracture as well as calcinosis, a little bit more in the early phase of the disease, that we were at least able to straighten out his contracture with treatment. You can see him standing straight in the next slide. And sometimes calcinosis can present, as you see in that X-ray, you can feel it all over the limb. The prognosis, 25% have a monocyclic course. These are the most rewarding patients to treat. 25% have a polyphasic course. If you recognize them, you can still keep them on treatment and maintain them well. And 50% have a chronic course. Some of these will be the heart-sink patients that we all have. Whatever you do, very refractory disease and very difficult to manage. Muscle atrophy, contractures, calcinosis, they can all cause very, very significant practical difficulties for these children. There is a small mortality risk. I have lost one child early in disease who unfortunately developed a viral infection with myocarditis, and it was not recognized in time, and the child died in her local center itself. The children who are more prone to die from the disease are those who have a non-JDN form of idiopathic inflammatory myositis, those who have antibodies TIF1 and anti-LDA5 and those with severe pulmonary disease. There are a lot of challenges. Diagnosis itself is one, because young children, the clinical pickup can be very difficult due to the heterogeneity in presentation. Muscle enzyme variability and throwing you off track is also something that we see in these patients. Delay in recognition, delay of access and referral to an appropriate therapy, tertiary unit in the beginning is really a big problem that we face. And for the same reason, lack of appropriately aggressive therapy at onset. The newer diagnostic measures and the MSAs can be very useful, but they are a resource challenge that we have. And I hope in the future we will have more targeted therapy driven by better prediction and diagnosis. Thank you.
Thank you, Dr. Suma Balan. Madam here has presented a plethora of pediatric cases, and you have proved how foxy these brats can be actually. Very difficult to pick up these juvenile parts. Now, one question which I have for you, madam, is in your clinical experience, what is the percentage of relapses that you have come across?
As I said, 25% have a polyphasic disease. And the idea is I would treat even the easily responding patient, I would treat them for a minimum of 2 years with methotrexate after I have stopped steroids completely. And only then think of weaning and stopping the methotrexate. And I found that that approach works better in our country, where getting the patient to come back for follow-up, all that can be a bit more tricky, and a relapse may not be easily recognized in the beginning, and so many other problems. Yesterday, I had a child with a relapse, and this was very, very surprising. He was a very young child at 1.5 years of age. We diagnosed him. He presented with panniculitis and fever. And somewhere something struck, and we did an MRI, proved the diagnosis, started treating. He'd done amazingly well. There was a small problem with the dispense of methotrexate, the last outpatient appointment he came 3 months ago. And it looks like he has been taking the wrong dose. He's been taking a much smaller dose than he should have, which probably was a reason for him to flare up. But we picked up, the mother is so sharp, she picked up the problem within 3 days of symptoms, brought him down. We restarted him now, and treatment, and he should settle down.
Thank you, madam, for a very nice talk. You have beautifully highlighted the differences between the adult myositis and the pediatric inflammatory myositis. So what is your take on anti-synthetase syndrome? Have you seen in the pediatric age group? And what is the role of nail fold capillaroscopy in managing juvenile dermatomyositis?
Well, I have seen the clinical variable that looks like anti-synthetase syndrome in a couple of patients. And one is unfortunately lost to follow-up after the floods. He has not come back to me. We were managing him with combination DMARDs and continuing high dose, not high dose, a small dose of oral steroids in him, and he was doing reasonably well. The other child had significant lung disease, and over time she dropped out of therapy and passed away, unfortunately. So there were two clinical, what happens with many of these patients is when you tell them that this, they've got this kind of problem, and they're going to need long-term therapy, and there's going to be a lot of other issues. The lung is involved, and there's a lot of other problems involved. They often go for doctor shopping, and then treatment doesn't actually go on the way it should, and many of them die. So I've not done the antibodies to actually prove it, because the challenge of just getting treatment going itself is difficult in many patients. Getting them to pay for the antibodies can be very difficult. Your second question was nail fold capillaroscopy. It is something that we should be doing more commonly. And with our PGs in now, we are actually starting to do more of it. But it's not something that I have been doing for a very long time before that. So I don't have a lot of experience right now. The other thing is, in the very early stage, many of these, I still feel that it may not help you pick up the early patients, because you'll probably pick up skin rashes in them anyway. My question really is, as we use more of it, whether the children who present with very difficult rashes where you wouldn't normally think of JDM, but you have a concern and you check a nail capillary and whether that can actually lead you to a diagnosis in those tricky patients, that would be where it really has a role to play.
Any pressing question for the madam?
Madam, just one more question. Anybody from the audience? Anybody from the audience? I have one small question. There's something coming up which I've read recently about the role of exercise in these children. Can you elucidate one or two lines on that?
Well, in the active inflammatory phase of disease, we don't advocate active exercise. We definitely want physios involved doing, making sure the joints are moved in range of movement and all, which helps to prevent contractures. But once they start getting better, yes, we want them to actually be active and to actively involve them in exercise, because it does help to prevent the muscle atrophy that can set in, which gives a kind of a long-term poorer outcome in physical ability to these patients. Definitely doing a good active exercise when they start recovering is a good option. Now, if you have a child with necrotizing kind of disease, you wouldn't want them to do active exercise for quite some time.
Thank you, ma'am, for the excellent talk. So now we conclude this session and we move on to the next session.
Thank you.